So, how many patients in America have kidney failure? This is actually from 2009 from the National Kidney Foundation's website. Basically, California's the third highest instance of kidney failure after Georgia and Alabama. And they call Georgia and Alabama, by the way, it's nicknamed the stroke belt because of type 2 diabetes, obesity, heart failure. It's kind of interesting that California is up there too. I don't know whether that's just in relation to migrant workers, because we do have a high population of Spanish workers on dialysis. But you'd think it would be better, because usually Californians take care of their health.
Well, we're in the good part. We're in the upper part.
Yeah, we are in the upper part, but we're still not as good as Colorado, which is actually actually one of the best places.
Texas, that's
yeah.
Deep fry central.
Yeah, I know.
Wait,
So basically, diabetes is the #1 cause of renal failure. It's about 44% of the population is diabetic. Hypertension is #2 at 28%. When I started kidney, work in the transplant unit, that was switched. Hypertension was always #1, diabetes #2. But in the last 10 years, it's gradually creeped up on the diabetes, and it's now #1 leading cause. But it usually comes hand in hand, as you know, you go out there, you're diabetic, you have hypertension. Glomerulonephritis is the third leading cause of kidney failure. It's around 8%. That refers to the glomerulus, is what the Bowman's capsule sits in. It's the filtering membrane before it goes down the distal tubule. It's basically the forefront of the nephron, so if anything's going to attack it, like toxins, it's going to attack it right there. Then there's other things: polycystic kidney disease, lupus, autoimmune disorders. There's certain types of vasculitis, granulomas, painkillers. People taking non-steroidals, they take their ibuprofen constantly, are at risk, especially if they're also drinkers and smokers and diabetic. Hemolytic uremic syndrome, I mentioned this one. This tends to be children. It tends to be an acute cause of renal failure, but it can cause chronic renal failure. It's usually in the summer months, barbecue season is when it's normally seen, and it's your classic undercooked chicken. It's semi-frozen, they cook it on the barbecue. The next thing they come down with an E. coli infection. Within 24 hours, those kids get very sick. They are vomiting, have severe dehydration, and they can basically expel blood. And they go into the red blood cells start breaking down as well. And all of that just impounds the kidney, and it goes into acute kidney failure.
Where does herpes strep go in there?
It's kind of the same. It goes into like a glomerulonephritis, and usually those can be reversible, but it depends again, what other comorbid factors are going on with that patient. Renal artery stenosis, basically, you've got those two little vessels going in, or sometimes there's probably one artery, one vein, but what sometimes happens is everyone has different anatomy, and sometimes there's two vessels and one, they're very small and they can stenose easier. And of course, drug abuse, which we're seeing more and more in this area, causing renal failure. Definitely the meth is causing renal failure in this area. So risk factors, again, it's kind of just summarizing it up. Heavy metals, something that people also don't think of, but some people have exposure, like Central Valley. There's heavy metals around the oil fields. People can't get renal failure because of that. In the old days, it used to be lead piping, and that would cause renal failure for some people.
Like touching a lead pipe?
No, it used to be water pipes were made with lead, so they were getting lead into their system. So, but like I say, the big ones there. Oh, and then of course we've got the obesity, hypercholesterolemia, thrombus. The other thing that can cause renal failure, which isn't really on there, is procedures, hospital procedures. So they go in to have their cabbage done, and when they do that, they have to clamp off blood vessels. Well, if you've got kidneys that are already struggling to get adequate blood supply, and now you clamp them off, there's a time frame to clamp those. And they used to say 20 minutes. I think they're even pushing that for like 10 minutes, because they're recognizing that people are going to renal failure. Some of our patients had never had any problems. They did the creatinine level of it. No problem, we'll be able to give you dye. You can go and get your cabbage, but no, they come out and they end up with renal failure. because of course we've gotten older and older patients on dialysis, 80-year-olds, 90-year-olds. So these are the signs and symptoms they tend to have: headaches, often urine output sometimes doesn't decrease, inability to concentrate with urine. Sometimes they actually have polyuria when it goes down to oliguria. In other words, they have a urine output and it trails off to nothing. So some of our patients on the machine still do make urine, but it's just the quality of the urine is not there. Obviously, BUN, blood urea nitrogen, and serum creatinine starts elevating. Again, if it's a slow, insidious onset, people don't recognize these symptoms. I've had I had a young guy once who was in his 20s working at Firestone Grill. Hadn't seen uremic crystals in a long time. This guy had uremic crystals. He was working with a creatinine that was in the sevens, high sevens. And it's because he just thought he was tired because he was working hard to provide for his family. And he came in with severe renal failure. Anemic, he was in the sixes. So how he was functioning, I do not know. So GFR is what we measure. It's the glomerular filtration rate. So basically that decreases down to like 30 mils a minute. It's indicative that they've gone into renal failure. So the doctors are measuring that in patients. They have certain degrees that they're recognizing that it's trailing off and they're going to this level of renal failure, and it'll start up as mild through down to chronic. They try to improve glomerular filtration rate by basically controlling blood pressure, diet, but at some point they know that that patient is probably going to end up on dialysis. They initially usually start with a mild anemia, but like I said, I have seen some patients come in with severe anemia. Blood pressure usually gets out of control because the whole renin-angiotensin system is just gone AWOL. And weakness and fatigue. The other thing to remember about dialysis patients is, especially when they're brand new to dialysis, is you can tell them something 3 times, 4 times, and their mental capacity of holding information is extremely limited. It's like they're in a constant fog. So you think, I just taught you that, I don't get it, why are you not listening to me? They are, they're just not remembering it. So you find that with the chronic patients as well. Yeah, and you think, really? Haven't I told you you shouldn't eat that food? They do. This is like another one, it's showing like signs and symptoms, the edema, puffy hands. If they're going in to see a chef, they're going to have, crackles in their lungs, they're going to show signs of that. Jugular venous distension, they're really overloaded. The thing is like they usually have men sexual dysfunction as well, because blood supply, the blood vessels of diabetics, it's just not happening down there anymore. What else is on that one? So they can get seizures, that's kind of rare. In the old days, we tend to catch it sooner now, but in the old days, like 20 to 30 years ago, it wasn't uncommon for renal patients to have seizures because of the fluid edema and the uremias. And it goes to the brain and they get edema in the brain and then they start having a seizure. But when you start dialysis patients, if they have really high levels, you have to give them a very, very slow rinsing and removal of the fluids and toxins, because you can cause a sudden shift and you could cause a seizure. I've only done it a couple of times, but we were trying to prevent it getting intubated when we were trying to pull fluid off quick and acute case. So what are the treatment options? So there's hemodialysis and there's peritoneal dialysis. So hemodialysis is what you guys are all probably used to seeing at the clinics. Basically removes toxic waste, impurities and fluid from the blood. And they have surgical procedure to get either a central venous catheter or an AV fistula graft. And basically the blood's pumped out of the body by a machine, via a filter, and then comes back into the patient's body. And the machine works on the processes of perfusion and filtration. And then peritoneal dialysis kind of does the same thing, but it uses the body's own peritoneal membrane as the dialyzing membrane. And those are the ones that have the Tenkov catheter placed through the abdomen. And they basically instill a dextrose-based fluid with a low-level electrolytes, because you need to have that gradient for it to come across the membrane. And that's where the osmosis and diffusion comes in, and the waste products can be removed. if I was to have renal failure, peritoneal dialysis is what I would have. This is what you know. It's continuous. They have usually a better quality of life. They can have a more liberal diet, and the biggest problem with peritoneal dialysis is infection. But otherwise, you can definitely control blood pressure better that way. Diabetics find it hard because it's a dextrose solution, but they use a different type of molecule called a dextran, and it won't cross over and cause them to have spikes in blood sugar.
So you, I don't know if this is
Yeah.
clear, but why do you get a choice? And
You usually, well, it depends. Here in America, compared to England, they're getting better about it. They never used to push peritoneal dialysis because they used to think it's a lot of supplies, patients aren't going to want to look after themselves, and taking away the responsibility of, because it's very easy for a patient just to go in and say, we're hooking up to a machine. Peritoneal dialysis, you have to basically say, I'm going to take care of myself, I'm going to take care of my body, I'm going to have strict aseptic technique, which used to be 2 minutes of hand washing when I first started. Now they do it for about a minute. But it really is, I mean, in the middle of hooking up your catheter, you've got to remember, you can't even touch your hair. As soon as you do something like that, you've got to wash your hands again. So in America, they were looking at more hemodialysis. They can make more money off it. Also profit versus quality of life. But there's better chance of you being in a better shape to get a kidney transplant if you've been on peritoneal dialysis than hemo. It can buy you time, because peritoneal, you can usually get, if you've looked after your catheter and you know had good technique and not had infections, you can get 7 years out of that catheter. Well, 7 years is the average time right now to get a kidney transplant. It used to be 5. We're really looking more like 7 years now. It's a long time.
I took care of a guy that did peritoneal for 14 years and,
Yeah.
and never missed a day of work.
Yeah, the average is 7, and that's it. And you can still function, you can still work. The problem with peritoneal is each exchange is a 2-litre bag that they're doing. And if you're doing where you're not doing the overnight cycling, which has now become more of the vogue to do for people, they used to do it, several times during the day. So people would actually take their bags to work because it would take about 30 minutes to basically hook up and drain out. So you think about how much space that is. And I say to American patients, you guys have bigger houses than the British. If the British can handle storing boxes under the stairs, and yeah, it doesn't look pretty, you put a blanket over it.
It requires taking responsibility for yourself.
Exactly,
which
but
is
it's just
not
like,
always-
come on.
Not
You have a big garage. It's like in England, you're lucky to have a garage. Most people have garages.
It's not very important for us. No.
But it's definitely about, like, if you want to take responsibility for yourself.
but you are free to go do stuff if you choose that, right? You don't have to
You
find
can
a
travel
dialysis
better with
center.
peritoneal
Yeah,
dialysis because you can actually arrange for the fluids to be delivered.
Yeah,
The
that's crazy.
companies will actually say, yeah, you want to go to Florida? Sure. Which hotel? Okay. We'll make sure your fluid gets delivered for you. So you can fly, get it delivered, and be on vacation. Where dialysis, you have to hope that where you're visiting will accept you, that they've actually got space in that clinic. And so 4 or 5 hours now, taking out your vacation time 3 times in that week. So yeah, I would definitely do peritoneal dialysis if I had renal failure. So that's just a quick picture showing like, someone's on the machine and stuff. Okay. So this is just showing like the peritoneal dialysis, and the peritoneal membrane basically is the membrane that encompasses all of the intestines, all the way up through to the liver, all the way into the diaphragm. It's actually really a huge surface area. Problem is if they get infections, it's also a very convoluted area for bugs to kind of grow and create nice little pockets of infection, and antibiotics can't get to it. Because also the blood supply to deliver the antibiotics, to get to that, treat that infection, is the membrane through the intestines for passing those antibiotics is not as effective as just the general vasculature of the rest of the body. So that's where you really have to have strict aseptic techniques. So yeah, if someone's blind or they really have poor dexterity, peritoneal dialysis is not good for them. So the idea is you basically have a catheter that's on the outside of the body called tin cup. It has holes basically throughout it. It's secured into the abdomen, into the muscle walls, sewn in, and there's what we call tin cup cuffs, and the tissue grows into it, so it can't get pulled out. And then it drains out the fluid, and then a new bag drains in. And you're usually looking at 4-hour dwell times is what you're usually looking at. And then when the fluid comes out, it's taking the toxins and it's taking the extra fluid because it's a dextrose solution, so it helps pull the fluid across the membrane. And you can play with that. If some patients need more volume to get pulled, they just increase the dextrose. But the dextrose itself is kind of irritant on the peritoneal membrane. So that also comes into play for the lifespan of the peritoneal membrane. So I just thought I'd show you this just because there are patients out there with a peritoneal catheters, just to show you what they look like. Basically, there should be always a cap. There should never be an open end on that. It's a closed system. What happens is if someone does get an infection, you can see if that end's come off as being loose. Might be a problem. It's going to be a really painful, hard abdomen. They're going to have fevers, and if they do have a fluid that they've drained, you can ask, if you're in their home, you say, hey, well, if you drain cloudy fluid, they usually know that they have to keep a bag, and they can take that bag with them to the hospital, and they can culture the bag, and it'll look milky. Because what it should normally look like is yellow. It should look just like clear urine, pale clear urine. But some of them can look red, because there might be even some kind of bleeding going on into that. They can look milky. They can look pretty disgusting. They can look green if the gallbladder is involved, because bile can get into them. So that's kind of showing progression of the exit site infection for that peritoneal catheter. I kind of see that it's a cloudy bag. It should not look like that. Other problems they can get, he actually had to have his catheter taken out. And they usually end up sometimes getting hernias because you have gone through that abdominal muscle wall. And they often do get hernias anyway because they have gone through that wall if they're overweight and just the stretching of it. So this is what we really want to know about is hemodialysis. So patients can go 2 to 3 times a week. They usually spend 3 to 4 hours on the machine. Some of them spend even longer, 4.5 hours, and some of the really bad, uncontrolled patients have to spend 5 hours. This county doesn't have many of them left. We try not to have them on the machine 5 hours because they're miserable. So basically, we have to take their labs each month, and that evaluates. They do creatinine clearance. They look at, we have a calculation called KT/V, which basically looks at the creatinine that's been cleared for that body surface area of that patient. And then it might be that if we're seeing that there's a trend in higher potassiums, hey, you need to do something about your diet. We have a dietitian in the unit that works closely monitoring these labs, also monitoring what we call the bone studies, the calcium, the phosphate, and the parathyroid, looking at do we need to adjust the medications for that too, because their calcium might be too high, might be too low, phosphate's too high, too low. And then the potassium actually can get altered in the bath of what we call the bathing solution, the dialysis solution on the machine. We try to have everyone dialyze on what we call a 2 millimole potassium bath, because most patients are coming in usually in the high 4s, low 5s. And the idea is that you have like a 2 on the side, so you're going to have that differential kind of dialyze across the membrane. By the end of it, we hope that we bring the potassiums down to the 3s. Fortunately, phosphate doesn't come across the membrane like that, because everyone thinks, well, you can do with potassium. Why isn't the phosphate being dialyzed out like it would in the kidney? Phosphate's a very large molecule. And it was really well described to me once to think about how the dialysis membrane works. If you have a colander full of different sized pebbles and then sand and grit to represent the molecules in the body, you shake it. The smaller ones are going to come through, going to leave the larger ones on top, and those are going to be the last to get through. So phosphate is one of those large molecules. Yeah?
What are sort of like signs and symptoms of hyperkalemia? Like if they do have high potassium?
Oh, I'm going to go through that.
I'm sorry.
That's okay. So I knew that was going to be a question.
Is there something that happens about the halfway point of dialysis? Because I feel like most of the time we get called and they're like, oh, they're about halfway through. I'm like, is there a magic something like, stop this right now, like now we have to call someone to go out?
We're going to go through that.
Okay.
I'm going to talk about what really is going on with that patient and why you're getting called.
So it's a thing. It is a thing.
Yeah.
Okay.
It is. Yeah. So yeah, there is. Good thing is that is all of the patients are screened